Thank you very much, Larry, for that kind introduction, and thank you for your time and attention today. It's a pleasure to be with you. As I told my guests, as my hosts, rather, my first trip to Lexington, Kentucky, so I appreciate that new experience as well. I want to first thank Doug Scutchfield and Larry Pribble for the invitation to be here today and to be part of this important conference. I also want to thank Paul and Bobby, and a month ago or so, two months ago, we got together along with George's Benjamin to talk about how hospitals and public health entities can work more closely together and what we need to do to help stimulate that. So I appreciate that new and important relationship. I also want to thank Mike Rust, our partner here in Kentucky at the Kentucky Hospital Association. Had the chance to meet with several of our mutual members earlier today, talk about the issues of the day. And I had a great tour of the University of Kentucky Medical Center this morning, something that I always enjoy doing when I can get out in the field. So I've been looking at your agenda as I prepared for my remarks today, and it's day 2 and you're back. That tells me that's a good indicator for those of us who run conferences. But I know that from the agenda and from the topics of your sessions, it's a very ambitious learning experience for you. You're probably swimming in new information and maybe new ideas and things that you're thinking already about how to take back home and adopt. So I'm going to give you a little bit of a break being your lunch speaker. I'm going to start with a couple of fairly simple questions and try to spend my time addressing them. So first of all, what's up with public health and patient health? And secondly, where do we need to go? And how do we get there together? Now, I'm honored that you'd give me time at your podium, but you might have noticed from Larry's kind introduction that he didn't mention that I'd ever worked in public health, and I haven't. So you have a true outsider. But it's not as though I don't understand the histories, the respective and joint histories of public health and patient health. Once upon a time, as most stories start, neither field existed. We had individual and community health problems fed off one another, and there was very little that our more primitive societies could do for it. Then for a while, the connection became clear. Individual health and population health solutions started to emerge and even built off one another. As we got better at one, the other benefited in both directions. But somewhere along the line, population health and patient health seemed to become divided by more of a bright line into two separate realms, few of us crossing from one to the other. From the perspective of healthcare providers, at least, public health folks worried a lot more about things like prevention, sanitation, food quality, large-scale interventions like vaccination efforts, and so on. And the large-scale interventions would truly improve community conditions and therefore improve individual health. As healthcare providers, including hospitals, well, we became more focused on the individual, on the medical and surgical, on the intervention, on the curing, the treatment, rather than preventing. We all had the goal of building healthier communities, but each sector had kind of a neat and tidy role of its own. Now, that's an oversimplification, but I don't think it's that far from the truth. And we find ourselves in a very different place today. We were all, along the way, always looking out for the good of our respective communities. And I think we also had a pretty good idea along the way, probably still do today, of what some of the reasons for the distinction, the difference, the line between us might have been. And not surprisingly, like a lot of things, not the least of them was that funding always seems to play a role. You know, when I was in consulting, a guy who was a very good friend of mine tried to jab me in the ribs one day, and he said, you know, you consultants are all the same. You're coin operated. And I thought for a second, and I said, you're absolutely right. I have a wife and 4 kids at home that want me to be coin operated. But it's really true for all of us. Financial incentives are some of the strongest incentives we have. So we, to borrow another line, I read Sports Illustrated yesterday on the plane on the way down, article on Jerry Maguire and so on, follow the money. And so the money is changing these days, as we'll talk about. And I think our relationship will change as well. So funny how financial incentives drive focus and behavior, especially when funds are plentiful and when we think we can afford the professional pride that says, my way is better, my way is a more noble way. Now the money's gone, and the public cares more about its health and the value it receives from us than it does about our professional turf or pieties. So what's the answer? Is it more public health? Or is it a shift in the medical model from treatment to prevention? Well, like most either-or questions, the answer is pretty clear. It's yes. Now, I've already admitted that there's no public health on my resume, but it doesn't mean that I haven't had experience in population health. And let me share a little bit of that with you, because population health, characterized by broad-scale wellness and prevention efforts, has actually a long history within the medical model. We were just talking about it at lunchtime here. When and if the financial incentives were there and the professional ethic had it valued and rewarded, you saw it. And you still see it today in the medical model. I'm referring to prepaid, multidisciplinary, integrated health plans. Call them HMOs or whatever you'd like. Probably in the future we might have some of them called accountable care organizations. But it's been there. Population health has been there. And I say, funny how much of a difference it makes when one is paid a fixed amount of money to worry about the health of a member over time, rather than a unit of treatment. When you run an HMO, public health is your ally. You want the patients who come in your door to be as healthy and devoid as preventable conditions as possible. But you know that your covered population mixes every day with the entire community. And your job is to keep your members out of harm's way, not just when they're in your office, but throughout their day, their night, any time that they are out there, because you're on the financial hook to take care of them. You use your face-to-face encounters with patients to reinforce the principles of public health. Sound living conditions, proper nutrition, health maintenance, prevention, wellness. Every intervention in a fixed payment system is an expenditure. And every expenditure is one of two things. It's either an investment, the earlier and the less costly the better, or it's a true cost. And all costs are bad when you're on a fixed budget. Just think about it at home. Principle is exactly the same. So it's simple, right? All we need to do, this is really simple. We could probably all go home if we just get this done by the end of the hour. All we need to do is change the financial incentives for our combined health sector and for individuals across society as well. All we need to do is incent health and de-glamorize consumption. Or to borrow a phrase from one of our recent AHA board chairs, what we need to do is create an epidemic of health. So how can we do that together? Well, like most things, it starts with a common vision. Let me speak from the hospital side. As hospitals move from volume-based payments to value-based payments, they're much more concerned about the connection between population health and their own efforts to improve outcomes, care coordination, and prevention, one patient at a time. From mobile vans and health screenings to education fairs, many hospitals have long been active in efforts to improve the population health in their community. But now they're becoming even more interested in improving the lives of their patients, not just their health care. And to be blunt, they're interested in losing less money as they are more and more underpaid from government sources. So rather than waiting for an admission that's not going to get paid or an ED visit that's not going to get paid, they're now much more interested in getting upstream on the primary care side or coordinating care better downstream after discharge.